we can use non-invasive mechanical ventilatory support or invasive mechanical ventilatory support. And when I say non-invasive, it's the bi-level, the BiPAP, right? Otherwise, it's intubation. So we do any of those to be able to decrease the patient's local breathing. That's one, okay? Another one is to be able to increase the patient's lung compliance, and that's where I have to explain to the clinicians. What is compliance? Compliance is the ability of the lung to expand properly. And when you expand something, you have anything elastic?
Yeah.
This is for the gym, okay? So this is not elasticity. This is compliance. It's the ability of this belt to expand. All right? But when I let go, it's elastic recoil. So the ability of the lung to go back to the initial state before expanding is elastic recoil or elasticity. And compliance is inverse proportional to elastic recoil. And you will tell me, oh yes, when I explain you this. Try to expand this. Pull, pull. It's hard, really hard. Why? Because it's new. Right? So, normally it doesn't happen, but if you now get a new rubber band and you start to pull and pull, what will you tell me? Please don't let go that fast because it's gonna hit me, right? So, when the fibers of the lung are tight, are rigid, the compliance is hard, right? Because I have to, I don't know if you have felt this, but I will pass around. It's super difficult to expand because it's rigid, isn't it? Mm-hmm. But if I let go, it's gonna recoil really fast, right? So that means that compliance is decreased, but elastic recoil is high. Right? Got it. Let me give you examples of disease process that can have rigid fibers. The leading number one is pulmonary fibrosis. The capacity of the lungs to expand in pulmonary fibrosis, really hard fibers, is low, but the elastic recoil is high. High compliance. Sorry.
No.
Low compliance, high elastic recoil. We're humans, we make mistakes. The opposite effect is when you have a crunchy, right? Brand new, how many loops? I don't know if you guys understand this. How many loops do you have to do to be able to do a ponytail? One or two, no more, right? But what about when it's old? Pantyhoses, underwear. Is the same quality, new or old? No, right? They're so boggy, right, when they're old, right? So, what do you think will be the expansion? The crunch is this size. You have to do 1, 2, 3, 4, 5, 6 to be able to do a ponytail. So the expansion is high, right? But when you let it go, it's still boggy, right? And the they have alveolar collapse and rupture of the septum and so forth, right? So one of the conditions that we intubate the patient is to increase compliance. You would see that patients with pulmonary fibrosis, advanced, they have to be either on continuous BiPAP to be able to survive, attached to a mechanical ventilator before they get transplanted. Increasing the tidal volume when you have restricted volume, right? When you have a patient with chanting, for example, with the ventilation being affected. To increase the inspiratory capacity of the patient to be able to blow out CO2 on the patients that have hypercapnia, right? Now, when you do BiPAP, the patient must have a GCS more than 8. Have you seen patients with a BiPAP? Yes. But mechanical ventilation invasive, the actual mechanical ventilator and ET tube insertion, is indicated in patients that have a GCS less than 8. And you cannot put the BiPAP in your exam on patients that have altered mental status. That patient should be alert. That patient should be cooperative. That patient shouldn't be agitated either because they're going to be taking off the BiPAP constantly. But if you're going to apply any type of sedation, the patient should not lose their DCS to less than 8. I had a patient the other day, come on. It was criminal to intubate that patient. And we fought with the family in a very nice way to get a DNI. The patient was Parkinson's disease advanced.
Oh my God. All contracted.
All contracted in the bed. Did we put the BiPAP on the patient? Yes. Should we do that?
No.
By test? No. Patient was only moaning. Was that? DCS is less than 8, for sure. You don't have to calculate. So that's an indication for intubation. Okay? The BiPAP, even though we also in clinical practice 3 days, 4 days, 1 week, even the patient's repop scheme should be a temporary measure, just to bypass the patient to avoid intubation. But if the patient continues to deteriorate or requires the BiPAP for more than 72 hours, you should think to intubate the patient, even though we don't do so. Okay? In addition, if you have a patient that is hemodynamically unstable, that patient shouldn't have a BiPAP, but intubation. If you have a patient that cannot control tracheal secretions or vomiting, I have seen that. They put the BiPAP, you would aspirate. You can't control secretion, you should be intubated too, even though we do otherwise. So, what else do we use the BiPAP for? Remember that we normally have a negative intrathoracic pressure. Positive atmosphere, negative intrathoracic, that's the reason why it goes from positive to negative, right? And that's the reason why we breathe. You're putting positive intrathoracic pressure, and when you breathe, when you take a deep inspiration, what happens to the preload?
No, if you take
normal, without BiPAP. When you take a normal breathing, because you have negative pressure intrathoracic, your preload increases. But if you put positive pressure higher than the atmosphere, you are depleting the preload. That eventually affects the cardiac output, yes, but one of the measures to use BiPAP as well is on patients that have volume overload and pulmonary edema and pleural effusions, you're decreasing preload and less fluid goes inside the lung while you're giving the patient's Lasix, okay? That's another measure. Sometimes many don't believe that everybody knows that, they should, or they don't apply it. I have seen many patients attending hospitals taking off the BiPAP because the O2 sat is 100%. I'm not doing it for such. Okay? All right? So that is one part, and the rest, you know, to go off CO2, etc. Okay? So basically, you know, while the patient is awake, of course, and you're not sedated because you shouldn't be sedated on BiPAP, you're preserving physiological function, right? The patient's awake, the patient's cooperative, right? You're preserving all the reflexes, you're avoiding intubation, and therefore, mechanical associated pneumonia due to the ventilator, right? Ventilator associated pneumonia. You're preventing tracheostomy and ICU length stays as obvious. All right? Now, many complications. Believe me that I know that many, if you're normal, rational, you can think properly, right? Because many patients are confused that it doesn't matter how much education you provide, they'll still take off the BiPAP. Mm-hmm. But believe me, many of us put the BiPAP on the patient and they never come to the bedside and explain why. And when you have a machine that is putting positive pressure and you are like trying to coordinate to breathe in, when you have negative instead, it's uncomfortable, really uncomfortable. But if you talk to the patient and you explain to the patient the reason why you're doing it, and if at the end you tell them, I'm doing this to prevent to intubate you, they will take it. They will take it for sure, unless of course they're confused and all that, which they shouldn't have a BiPAP, okay? So always think about the secretions, right? Because you know nursing nowadays, unfortunately 6 to 8 patients is impossible. And respiratory therapists, even less. I don't know your hospitals, but at Kendall, they cut down every day and they have less and less respiratory therapists to suction patients. It's really unsafe to have these patients on BiPAP when they're drowning on secretions, okay? Remember this, gastric distension. When you are on the BiPAP, doesn't mean that you cannot eat. But if you're allowed to eat, small quantities. Because when you put the BiPAP on the patient, not only, unfortunately, you don't have a secure airway, so the gas goes into the lungs and goes into the abdomen as well. And when you inflate the gastric outlet, vomiting and aspiration pneumonia. So be careful. The patient is under distress. Well, again, I know that the patient shouldn't be on BiPAP, it should be intubated, but we always give a trial. Clinical, not test. We always give the benefit. Let me give you 2 hours and see how you do. Don't feed the patient if you believe that this patient might end up being intubated, okay? Remember that because we decrease preload, okay, that fluid is gonna go backwards, right? And these patients will also have extremity edema. Just tell the patient, tell the family, because they get concerned, okay? And you're basically buying time. Now let's talk about the cities, which is what you love. How should I start a BiPAP? There is 3 parameters, well actually 4. One is called IPAP, inspiratory positive alveolar pressure. So what is inspiratory? Your inspiration. So you have to take this as your respiration. Inspiratory partial or positive alveolar pressure. Okay? EPAP is the opposite, expiratory. have your FiO2, and then you have your backup rate. Tell me what's the normal respiratory rate?
12 after 20.
So, what would be the number that you will start on any inspiration? 12. You start the minimum first, right? 12. And, or expiratory positive airway pressure is the amount of pressure that is left over at the alveoli at the end of expiration. How much is that? 5. So think about your EPAP as your peak on a ventilator. Do you understand? Okay. Your FiO2, even though we have a way to calculate, which I'm not going to go there, and we have a table and the AO gradient and the FiO2 PaO2 ratio and all that, the FiO2 on your exam, on any patient that you start for the first time on a BiPAP or ventilator must be 100%. And the backup rate on the BiPAP is no more than, if you fail to breathe 12, you breathe less, I'm going to give you the volume of pressure. Do you understand? All right. So the backup pressure cannot be over 12, right? It has to be less. So imagine that you don't want the patient to hyperventilate. Let's put 8, let's put 10, whatever number you want that remains normal, right? I know that you're hyperventilating, but I don't want you to breathe less than 12, so let me give you a backup pressure of 10. So far, so good? Good. Now, let me give you an example. It's not rock science. 726. I have 72. I have a PO2 of 84, and forget about the rest. Because for the BiPAP, it's not truly necessary the bicarb and so remember pH, CO2, okay? Forget about that. What do I have? Respiratory acidosis, right? My problem here is the CO2. I want you to blow out that CO2. What's the only way? Hyperventilate. How do you hyperventilate?
So put it to 20? No, iPad? In 15 to 20?
Yes. Yes. Okay? Now, in pulmonary physiology, it says that the sum of the IPAP and the EPAP should not go over 20. That is in a test.
Okay, so in a test.
12 plus 5, 17. Right? So that means that some book says 25, but again, never, never, never over that. But guys, if you have to stay at 5, mandatory, and you now have a PCO2 of 72, and I go up for every rate that you increased, the CO2 will go down 10, 14. I'm expecting 62. But it's still high.
42, it goes down 10, you said?
10. 6 to 10, no more than that. If I go 16, I'm expecting this to go to 52, which is very close for a patient that's COPD patient. But 16 plus 5, it's already 21. So what can you do? I want you to know by your exam that if you need to increase your inspiration to blow out the CO2 because the patient is in respiratory acidosis, you increase the IPAP. What about if I now my problem is oxygenation?
Increase the P.
Exactly. This is my problem. You will see it better if I tell you, listen, this doesn't apply to BiPAP, this applies to mechanical ventilation, but listen to me. If I tell you that in mechanical ventilation, listen, I'm jumping, but it's applicable, okay? If I tell you that in mechanical ventilation, you get first the rate, then the tidal volume, then your FiO2 in the formula, right? And then your P. If these two control the CO2, and these two control the oxygenation, what will control my oxygenation in the BiPAP? The EPAP. So to be able to increase oxygenation, not only you can increase your FiO2, which you can't do it anymore, right? Because it's already 100%. You could also increase the EPAP, which is your pressure and pressure at the pressure left over at the end of expiration in the other line.
So how high can you go on the BiPAP, on the EPAP?
I think a different thing.
7, no more than that. Because if you need a high, if you need a high EPAP on BiPAP, you must be intubated. Okay? Now, did I tell you that the higher the pressure intrathoracic, the less the preload, the less the fluid in the lung, and it's applicable for CHF pulmonary edema patients, pleural effusions. So what about also increasing the EPAP or the PEEP in the ventilator to allow less preload and help the patients with pulmonary edema?
Right.
You had a blackout because.
Yeah, I was like watching and I was like, what?
Okay, again.
Sorry.
That's a good question. So if for some reason, just going back to the previous example, you had to go up to 16 on the iPad, would the EPAP have to be part of it?
No, I don't touch the EPAP at all. Why? Because in the first example, my major problem was hypercapnia. The only thing I have to do on that patient is make them breathe faster. That's it. Now, sometimes you might see us manipulating both. Why? Because if a COPD patient has heart failure and they come in with a mixed, didn't I tell you at the beginning that you have a type 1, type 2, mixed, type 3, type 4? So what about if the patient comes hypoxemic and hypercapnic and they have pulmonary edema? Well, I increase your IPAP, I increase your EPAP, and FiO2.
Everything.
Or no more
Okay.
than 20.
No more than 20 by the book. Okay? We have examples. We have examples. Okay? So what is IPAP? Inspiration, your respiratory rate. EPAP, expiration, your amount of pressure left over at the alveoli at the end of expiration. And that's like a peak, right? So, again, BiPAP or intubation, they have the same indications, right? We already went through those. Now, when the patients cannot maintain their weight, they're not going to put the BiPAP at all, right? Mechanical ventilation. We have examples out there. Okay, as I told you, in mechanical ventilation, you have different modes of ventilation that we're going to go through, right? You have assist control, you have pressure control, you have synchronized, intermittent, mandatory ventilation is there, okay? And you have continuous, positive, alveolar pressure. Okay? You also have pressure support ventilation, which is basically what you apply on any of the SIMV or CPAP in case, again, it acts the same way as the backup pressure, backup rate on the BiPAP. If the patient fails to breathe this amount, I will give you a help. Okay? The settings are, again, rate, tidal volume, FiO2, and P. As I told you, if you need to manipulate the CO2 because it's elevated, you will only act, increase or decrease rate and tidal volume. No both, either or. If you need to increase oxygenation, you will manipulate only FiO2 or P. Okay? No both at the same time. One first, then the other. Depending, for example, use the RDS. What will you do first? You will, don't touch the tidal volume after you calculate it. You are already at 100%. What else do you have to do? Increase your P. Okay?
What's the maximum tidal volume?
Go there.
It's 4, 6.
Again, what is your normal rate? 12 to 20. What is the normal number that you see all the time when you start a ventilator? 12, right? Because that's your normal rate. The minimal rate of breathing, being normal, right? The tidal volume has a formula.
4 to 8.
And I told you, no, that's even more than that. The tidal volume has a formula. And as I told you, if you don't have ARDS, you start 6 to 8 ml per kilo. And I will choose 6. And if you have ARDS, you start 4 to 6 ml per kilo. And you will see that we normally start at 6. So the guideline says that you choose the minimal average tidal volume for all, right? And if it doesn't work and you need to manipulate the tidal volume, go down to 4 then, okay? In addition to that, the tidal volume is calculated based on ideal body weight, not your regular body weight, okay? The ideal body weight even though we can download an application and just plug the numbers and it will tell you, but unfortunately for your exam you have to calculate it yourself, okay?
You know that this new exam sub doesn't have calculator, right?
No, sometimes we forget to plug it, yeah. Okay? Alright, so the ideal body weight is based on gender. And is 45.5 plus 2.3 times the height in inches minus, it's easy, lose it, minus 60.
Height, 2.3 inches. 45.5. What inches is that?
45, this is female. 45.5 plus 2.3 times, because this is multiplication, height in inches minus 60. And the male is the same, but 50 plus 2.3 times height in inches minus 60. If I tell you that 1 foot is 12 inches, you need to know that too, okay? And if I tell you that 60 inches is 5 foot, calculate 5 times 12. 660, right? So, how tall are you? 5.8. So, 5.8 times 12. How much is that? 16. Guys, you have to participate because otherwise you're not going to get it. 70, right? So, his ideal body weight is 50 plus 2.3. How much? 70 minus 60. So that means that it's 50 plus 2.3 times 10.
160 pounds. He's supposed to
How
weigh.
much is 50? How much is 2.3 times 10?
23.
23.
So 50, so
73.
Yeah. 160 pounds.
73.
Times 6. Where's that 6 coming from? From the 6 to 8 mLs per kilo.
Then you start with.
How much? We're going to practice more. How much is 73 times 6 mLs per kilogram? That needs to be my tidal volume.
438.
438. So that means that when I start him on mechanical ventilator for the first time, his orders will be AC, which is the most common way of ventilating a patient, the most common mode. AC of 12, 4.
438.
How much is the tidal volume calculation?
438.
438, which we normally don't do 438. You would see 430, 450, but never go over 430. Do you understand? Never go over 430, 100% plus 5. You want to do yours? How tall are you?
I'm really
short.
I'm really easy on 5'8".
No, but give me a different number.
I'm sorry.
5'2"?
Yeah.
Okay, if I tell you that per feet is 12 inches, 5'2" times 12, huh?
It's
62, right? So, she's a female, so I have to do 45.5
300.
plus 2.3 times 62 minus 60.
It's 62.4 though.
Right, doesn't matter, 62. Okay? So, this is what? 2 times 2.3, 4.6, plus 45.5,
50.
huh?
50.1.
50, times 6,
300.
300.
that would be your tidal volume, right? 300. So, her orders will be AC of 12, 300, 100% plus 5. Is that difficult?
No.
So mostly what's always kind of like realistically changes in the tidal volume. You're really not gonna change. So
Yeah, but that's to start.
start, unless obviously the patient.
Inches to foot is really common right now.
No,
But we're only
the conclusion, the taller, the tidal volume is gonna be higher.
5.2 times 60, isn't it
No.
supposed to be 12?
Remember that 1 foot is 12
So
inches.
why is it 60? That's why I'm so confused.
5 times 12 is 60.
Oh, but I'm just, okay, but
That's
Plus
part of
the
the
two.
formula. The
Because you're
60 is part of
5'2".
the formula. So you
Okay.
insert your height in inches minus 60.
But tiene que ser
I'm doing 5.2 times.
How tall are you?
No, because your 5 is to be.
5 times 12 plus.
Yes.
Oh,
5'8". Wow, that's it.
5'8".
6'2", perfect. Her foot is 12 inches.
Yes.
6 what? 6'2". 6'2" times 12.
Okay.
72, and then so 74.
We just applied the number, that's why you got lost. We just put the number.
74.
74?
Yeah.
Okay, 74. He's a guy. So that formula that I have to apply is 50 plus 2.3 times 74 minus 60. 74 minus 60? 14. Times 2.3.
So, 2.3 times 14.
32.2.
It's 493.
32? So 32.
Times.
Okay? Plus, no times, plus 50. 82. It's 0.2, it's not over 5, so these are 82.
So,
Times your tidal volume, right?
492.
What is that?
492.
492. So you will believe that this is very close to 500, right?
Yeah.
It's closer to 500 than to 450. Yes or no?
Yes.
Okay, so his calculation, I mean, the order will be 500.
Didn't you say if you need more than?
Don't do more than 430.
In the other case, it was 330 something, so I left it at 330, you know? Since it's 6 to 8, you can go a little bit over, but not like to the extreme, because if you're 330, you're not gonna jump to 350.
Yeah.
It's 20 more, instead of like only like, 8 more.
Is this a limit
No, honey, it's just, remember,
based on weight?
you're still safe because it's 6 to 8. If we do the same calculation, but instead of times 6, you do 82 times 8, how much is gonna give you?
656.
Almost.
Huh?
656.
Here, 656,
That's a lot.
that's a lot. You see, that's the big change. So I can stay at 500, not a problem. But if I have 320, 330 something, it's better to stay at 330 than to go over 350.
Because we're gonna do 340?
It is fine, but you're 332, you're closer to 330 than to 340. It's fine if you do 340, no problem, but that's kind of like an odd number.
Okay, I have to work.
Now, you will see residents that will leave it at 338.
Wow.
And you will be like,
I never seen
Who
a
did this?
respiratory drop between those miles.
I understand that.
My God, that's great.
Okay, my point is that I understand what
I
you're
need
saying.
one.
But the thing is that you say that, for example, that 500 is the tidal volume. So why, then you have a 6 point tidal volume in the corner. And then you have 500 over there.
where did I get this 500?
No. You're saying that 500 is the tidal
Tidal
volume.
volume.
So why you have 6 here? Why you start with 6?
Honey, because we start in a normal patient, except ARDS, 6 to 8 mLs per kilogram.
Yeah, but when you are calculating the body weight, ideal body weight, that should be ideal body weight.
No, my ideal body weight is 82.
Yeah, but the formula, it says ideal body weight is the double calculation. So that's why my confusion. So it should be the rate, ideal body weight, and then
No,
FAO2.
no. Because what I'm placing here, listen to his question. The formula here, he says that it should be ideal body weight instead of tidal volume. No, because the tidal volume is based on ideal body weight, and I calculated that. He might tell me that his body weight right now, how many kilograms are you? 100. So if I calculate him, his tidal volume based on, remember, 6 to 8 mLs per kilogram, this is the actual body weight. If I calculate his tidal volume based on 100, instead of an 82, I will produce ball trauma on him. So that's the reason why I need to know his ideal body weight first, which is 82 is to not 100, to then calculate this ideal body weight times 6 to 8 mLs per
So
minute.
pretty much you only go low just to be, prevent the thing.
Okay, 100 times 6 will be 600.
Exactly.
So what is the measurement of the tidal volume? The unit of the measurement?
mLs.
mL?
6 to 8 mLs per kilometer.
Okay.
But these
Yeah, I
kilograms,
understand that, yeah, because the 6 does not belong to the ideal body weight formula original formula.
No.
That's why.
Yeah,
this is tidal volume. And the original formula that I placed here is ideal body weight. So
Okay.
tidal volume is equal to 6 to 8 mLs per kilo of those kilograms of ideal body weight, not actual body weight. So in order to know how much tidal volume I should place on a patient, I need to first calculate the ideal body weight and then multiply it by 6 or 8.
Sí, porque si the person is obese, then you go
Oh,
way above.
Oh, that's another part. That's another calculation that we have here. If it's underweight, or if it's
There's some
overweight.
people that are
So why
5'2" and they weigh like
Why
400
can't we just
pounds.
take the patient's body weight? Why it has to be ideal body weight? Why can't you?
Because the size of the lungs go by your height, not by your
By the
weight.
height. Exactly.
Yeah,
Because
the
then
size
it's
of your
not by
lungs.
your height, because the
Yeah.
problem is that if you give that alveoli the actual body weight, you can explode it.
100 total.
But if the patient is.
The alveoli has nothing to do with your fat. Nothing.
One negative.
I need to know exactly what you should weight to provide that alveoli expansion or compliance. Exactly. But I can't do it based on these people that weigh 600 pounds. I can't. I would explode the alveoli. Okay? All right? So again, if you need to now, let me give you an example. And then we'll go through the settings. Let me erase all this. We ended up with William, right? Finally, I know somebody. Okay, this is William on the ventilator. Initial settings. Imagine that I now have, give me a pH,
7.3.
32. My part, I'm sorry, CO2, 65. And then I have, imagine that 100%, I am on just
85.
okay, it's 285, really bad. Bicarb again is 24, and base is minus 2. Okay, so what's my problem here? I have acidosis here, I have acidosis here, normal, normal, in quotation normal because the A ratio is really high. Okay, so tell me, based on this ABG, what do I need to do?
Adjust the rate.
I have hypercapnia. I need to blow out that CO2. And I know that if I want to manipulate the CO2, my only two options are the rate and the tidal volume. In essence, let me tell you guys, when do you see practitioners moving the tidal volume is when they just do it at a glance. 500, 300, 600, but they don't do a calculation. That's mostly in the ER, right?
Yeah.
So that means that if you truly calculated your tidal volume based on ideal body weight, the first thing you should do is rate. So if I'm at a AC of 12 and I have 65, I'm not going to ask you how much because you're beginners. Your answer is increase rate. And that's exactly the way, unfortunately, they're going to ask you in board examination. Go up on the rate. Be safe.
So then would you,
Go to 14 and do an MBG in 30 minutes or 1 hour. And if you have to go higher, go higher. All right?
would you assume, again, that if you go by a rate of 2, that it would decrease by 10? So then, right, so then you would, but you wouldn't want to just increase the rate of 4 off the bat, you would want to do it slowly, like 2 by 2 by 4. Like
Some
you would-
practitioners
you
don't do it
wouldn't-
because
you wouldn't calculate off the bat that you want to decrease the patient by that much, you want to do it slowly, regardless.
Exactly. Now, imagine that his ABG, on the contrary, is
Thirty,
90 to 100 is the normal SPO2, right? And in 100%, with your PA ratio, which again, I'm not gonna take you there, but you know for a fact that if a patient is at 100%, you should triple that number. You should triple that number on a ventilator. So you're expecting here at least 300, and you have 75. But I'm already at 100, and you know that to be able to increase oxygenation, the only 2 parameters is the fire 2 and peak. I'm a peak of 5, but I'm already at 100%. What you should do?
increase the peak.
Can you repeat that again? Right, but then you wouldn't want to go past 10, you said you want to stay to 7 or 8.
No, it's not, no. Okay, the ARDS.net says that you should try not to overpass a peak of 10. But if you have to do it, you have to do it. But once you are a peak of 15, even though I see 20, 25, and so forth on assist control, that means your volume is not working. You need to change to pressure. And that's when you change from assist control, which you're gonna see all the modes now, to pressure control. Okay?
And then you
Reverse ventilation.
Then you change all your settings again.
You work based on volume. Your lungs don't work based on pressure. The PEEP is just the leftover pressure, right, in the residual flow. All right? Now, if on the contrary,
Increase the apparatus.
increase,
Increase the
It's too much.
So how do you know how much?
Too much fun.
Maybe 50.
there's a formula.
Oh.
But again, guys, do it slowly. You have 100 and 385. I will, based on the X-ray, because you also have to see clinical X-ray. Because if you have 100 here and you have a 385, and you have a patient with large effusions, you're not going to go down to 50, right? It's too much, right? If you have a normal X-ray, or better, improved, drastically improved X-ray, and you have 100, and you have 385 here, you will be safe with 50%. But again, we normally have a calculation, a formula. We even have a PEEP table. This amount of PEEP that we used, I can open it for you, this amount of PEEP will give you this exact PaO2. But we normally do it at glance. So if you have 100% and you feel uncomfortable because clinically the patient, you have a shallow breathing and you have a chest X-ray that is still bad, still looks ugly, go down to 90, 80, go slowly. That's clinical practice. Nobody's gonna ask you by exam right now at this level, how much? Because we have a formula. So the only thing that I want you to know is that you're at 100, you're tripling the value.
Yeah,
We need
increase
a
the
five.
average, right.
Do you understand? If I now have a patient at 100%, and I have, for example, 125, this is a completely normal ABG, and I now tell you that my patient has mitral regurgitation and my patient has pulmonary edema. what value on the ventilator I should manipulate.
Peak.
The P, why?
Because of
It
the
increases preload. In this case, I don't wanna do this because I'm oxygenating properly, even though it's still borderline. I am not manipulating the P because of oxygenation, because I'm fine. I am not manipulating tidal volume or rate because my CO2 is okay. I am only increasing the P to 2 more. 2 by 2. Because I need to decrease the preload. Now, have in mind, this is another part that is asked constantly. Have in mind that every time you decrease the preload, you could also decrease the cardiac output. And the patients could become hypotensive, and the patients can have increased intracranial pressure. So never ever increase your P on a hypotensive patient that doesn't have any type of vasopressor support. So if you're giving fluids, or you're starting a patient on vasopressor because the patient's hypotensive, don't go up on the people unless you're gonna hook up the vasopressors, right? And never increase your P if the patient has cerebral edema with midline shift and an increased ICP. All right? Contraindications for BiPAP. We're going back and forth. Applies, it applies. I was the one who jumped, okay? Makes sense that if you cannot maintain airway because you had a cardiac respiratory arrest, you're not gonna put the patient on BiPAP. That's common sense. The patient is this all common sense that we have said it. Patient that is hemodynamically unstable, right? If the patient has any hemodynamic instability due to rapid fever, flutter, the patient is on VTAC, the patient has an acute myocardial infarction, right? If the patient is unable to protect airway, the patient's agitated and fighting and taking it out. If the patient is vomiting by any cause or having upper GI bleed, makes sense that you're not going to do it. If the patient is severe hypoxemic, you should intubate the patient, not put the patient on BiPAP, right? Unless you know that the family is still, and that's clinically. Because if the patient is still hesitant to put the patient on a CMO or not, or hospice or whatever, let me tell you what has happened. If you don't document, you never did, and the family can say, it was never explained on my patient, my family member was a full code and they never intubated. Okay? So be careful what you do. If a patient we had a patient the other day that he was poor guy, bicycle riding, 27 years of age, cyclist. They were training with a trainer to do a competition. There were like 10 of them, and a car hit one. And he fell face down on the road and had major facial trauma to the point that the maxillofacial surgeon couldn't even, he was taken to the OR and brought back because they didn't know how to put plates on that face. He was nasally intubated. You can't put a BiPAP on.
Nasally?
Okay? Yeah. As a tube only my nose. All right?
But it wouldn't,
So,
like, that be an implant, because, they would have to check that he
His mandible was gone.
What?
Can't
But
mandible.
Are you supposed to do anything through the nose if you?
Yeah, like they would have had to
Doing
see that he
tracheostomy?
have a maxillary, right, fracture.
That's what I would do first, tracheostomy.
Yeah.
Or nasally intubation.
I thought it was one of the contraindications for a facial.
Well, one of the absolute contraindications for TPA is severe trauma. I have seen TPAs on severe trauma.
So everything we're learning just.
No, but you would see a lot of deviations from guidelines, yes, you would see a lot.
Yeah.
All right? So this is a case that's practiced. You have a patient, 65 years old, COPD, admitted to the hospital, receiving 3 liters nasal cannula. Significant shortness of breath after bronchodilator therapy. This is a patient on distress. Sometimes it doesn't show truly by respiratory rate. Look at the vital signs. Even though I know this is abnormal, if the patient has tachycardia and hypertension, that's a sign of distress, even though the patient is using accessory muscles, right? This patient is in respiratory failure for sure, okay? Now, look at the ABG, 724. Acid, hypercapnic, that means that patient is tired, okay? Hypoxemic, so you have a respiratory acidosis with hypoxemia, and even though, look at the 34, this patient is already chronic compensating due to the COPD,
But it could be an
this
extra-
patient must be intubated, okay?
Because of the CO2.
And you know already how to calculate the idea body weight. Let's talk about modes of ventilation. The most common mode of ventilation that you will start the patient on is called assist. Listen to the word, assist control. Or, in the past, used to be called control mandatory ventilation. The word assisted means that even though I will preset rate and tidal volume on the patient, you preset actually everything. You preset the rate, the tidal volume, the FiO2 and the P. But the only two things that you can control, okay, on a ventilator is the volume and the pressure, okay, and rate. But listen to this. Assist control means that even though the patient can't initiate their own breathing, every time the patients breathe or not, the machine will mandatorily give them the same rate and volume. So, okay, let's say it again. You are intubated and sedated, right? If you are sedated, you should understand that sometimes you will hyperventilate, right? If I set up the ventilator at a rate of 12, if you breathe at 12, I will give you, William, a tidal volume of 500. That was his number of calculation, right? Every time he breathes at a higher number, 15, 16, because it happens, right? Because you can breathe on your own. You still get the 500 no matter what. So in other words, that's the reason why that is, even though you preset the volume and rate, regardless of the patient's own effort, the machine will deliver the same preset tidal volume. Got it? So, if this is at, again, 5 millimeters of mercury or centimeters of water, which is your physiological peak. And so you can understand better the graph. This is your 5, right here. This is 0, it never happens, right? This is the patient, look at this. This is the patient taking an inspiration. And the patient expires, right? Inhales, I'm sorry, exhales. Right? Now the patient is breathing normally on their own. If you breathe normally on your own, you go a little bit negative, and then you breathe again. Don't you have a normal negative interfacing pressure? And the patient breathes on their own again. And the patient is not breathing on their own, and the machine is still delivering. So that means that even if the patient breathes over 12 or not, the machine will still deliver 500 mLs of tidal volume. That is assist control. And it's called assisted control because, again, if you breathe less, if you breathe more, it doesn't matter to me. I'll give you the same. It's like a spoiled child like mine. If you work or don't work, I'll still support you. Right?
What are you doing?
Now, if I am delivering volume because assist control, let me tell you the modes of ventilation again. You have assist control, you have pressure control, you have synchronized intermittent mandatory ventilation, you have pressure support, you have continuous positive alveolar pressure, and you have PEEP. Listen. Assist control is a mode of ventilation, no pressure. You're delivering volume. That's the primary setting that you're delivering. In the pressure control is pressure. In synchronized intermittent mandatory ventilation is volume. In pressure support is pressure. In continuous positive alveolar pressure is pressure. And in positive end expiratory pressure is pressure. Yes? Yeah. So, if in assist control and in SIMV, I am delivering based primarily on volume, that is what I can guarantee. So what fluctuates? Pressure. I cannot guarantee pressure even though I put a PEEP of 5. That's only your physiological 5. Do you understand? But if I increase to 7, 8, 10, or 15 on an assist control, that will fluctuate. That will fluctuate. I cannot guarantee you a 12 or 15 because my assist control is based on volume. Do you understand? For me to guarantee you that PEEP of 15, I have to switch the ventilator to pressure control. Do you understand? Okay. So, another mode.
It has to be a protocol per person, like you have to go from, it's mandatory to go from AC to pressure support to the steps, or you can.
I'll tell you now. Let me go over all the settings. I mean all the modes, and then I'll tell you it. This is the graph that I basically explained.
Is PRVC the same as AC?
Huh?
Is PRVC more the same as the assist control?
It's better. It's better. Why? Because the problem is that the patient is allowed, has the flexibility of pulling out their own volume and pressures. So you actually can have the variations of mandatory set volumes, and the patients can take also their own. Very similar to SIMV. PRVC is another name. Okay, another level. See, because it's a combination of AC plus SIV. Okay? So, let's take basic. right? Because if we continue to go at a higher level, you will be lost. Now, another mode of ventilation, because it's not here in your PowerPoint, is pressure control. Let me tell you what pressure control is. Again, this is the graph, remember? The 5 peak, right? The physiological peak. So the patient here will take a deep breath, inspiration. And I can guarantee pressure, right? This is pressure volume. So basically, in the assist control, the graph, you would see it most of the time as a bell. Okay? Because it's volume and the plateau pressure will not stay as long, right? Because I'm not guaranteeing pressure. I'm normally giving your physiological peak, and that's it. So, but the pressure control, the graph is going to be more like this, more square. Okay? So you have an inspiration, pressure applied to the alveoli, and then expiration. So, what I have to give in the parameters of the pressure control ventilation is, so if assist control is that I am presetting, the definition is, I am presetting tidal volume and rate regardless of the patient's own effort. What do you think pressure control will be? I am setting up pressure and rate, and I will deliver this amount of pressure regardless of the patient's own effort, right? But the variation will be in volume. So that means that if the volume, even though I still have to preset it, if the volume that I preset on William is 500, I cannot guarantee this 500. And you will see on the ventilator that the patient would have a pressure, for example, of 20. That is guaranteed, but the volume will be varied. So here you would have like this, another one higher, another one slower. The pressure will remain the same, but the volume will have variability. Okay? Now, in this mechanical ventilation mode, the parameters are like this. Remember that in assist control, you give a rate, right? You give a tidal volume, you give it 5-2, and you give peak. Okay? I need to know how much pressure I need to put in that alveoli at the beginning of inspiration until the end of expiration. Do you understand? So I need to know exactly how much longer you want that pressure to stay. Okay? So you still put the rate, even though you can tell the tidal volume, you cannot guarantee that. Right? So sometimes what they do is basically they put the rate of the ideal body weight, and they see what, because when you put pressure control, you have to stay at the bedside. Not all the patients tolerate it. Okay? So you have to stay there for a little while and see what the patient does. So first of all, you need to see how much volume they put on so you can adjust based on the machine. Right? But what can you set up and guarantee is pressure. So first, you put the pressure, okay? And we normally start at a pressure, this is not PEEP. The pressure is this amount of pressure that I'm applying on the alveoli between inspiration and expiration, no more, okay? So I start with a pressure of 20, that's a set, initial set, and I have to give the pressure inspiratory time. And that time is no more than the ratio, this is more complicated. This is more than the ratio of inspiration versus expiration. Remember that we normally breathe 1 inspiration and 2 expiration, right? So we will start, if you are already at a pressure control setting, you start, remember that the ARDS advised you to start 1 to 1, right? Right? And then you do the FiO2, and you do the P. I need you to make you aware of the pressure control, even though on board examinations, they don't ask you pressure control because it's highly difficult to manage. Not because of the settings, because the numbers anybody can plug those. But again, the patients become sometimes hemodynamically unstable when they're set on pressure control for the first time, so you need to be able to see if the patients are able to tolerate. Yes, tremendously.
The settings for the pressure controls, the P, 20, the PI, the FI, the P, yeah.
Yeah. Okay? The only thing that they ask you is, what is pressure control ventilation? That's it. Okay? So, what is synchronized? Listen to the word. It's not difficult to know the definitions at all.
Isn't that the one that you can breathe over?
Correct. Synchronized, intermittent, mandatory ventilation.
If you don't breathe, breathe.
Exactly. But at the same time, let me start from the beginning. Synchronized means that the amount of volume will be synchronized by the patient's own breathing. So, but if you don't breathe, I will give you a set volume. I am allowing you to breathe independently at your own volume, but if you don't breathe, I will push a preset volume. Got it?
Mm-hmm.
If I am breathing now, if I set up the SIMV at 12, if you breathe 15 and you pull out 300 instead of 500, that's fine with me. So you could have a variation. So again, the patient is allowed to breathe independently at their own tidal volume that they pull. But if you breathe under 12 at 10, if I calculated and I preset the machine at 500, I'm going to give you 500. Do you understand? Okay? So, as I said, like assist control, it will deliver a minimally to fully assisted breath. So if you don't breathe over 12, that's fine with me. 500, 500, 500, 500, 500. If you breathe less than 12, 500, 500, 500. But if you breathe over 12, I'll leave you alone. I'm just squashing. Backing up. Right. Okay? That is synchronized intermittent mandatory ventilation. That the difference with AC is that if you breathe on your own, I don't care. I will give you 500 no matter what. Okay? SIMV is a mode of winning that we less and less and less use it. It's true, but if you see that the patient by ABG, by X-ray is ready, but clinically is weak, and you want to recruit muscles and allow the patient to breathe on their own and pull and improve their volume, put the patient on SIMV.
So that's the one they use to extubate?
Not right
To
from there.
start winning
Weaning them off, like you would put them on AC and then just
Now,
try to send.
the guideline doesn't recommend you to go straight from AC to extubation or from AC to CPAP, even though we do it. The guideline recommends that you go from AC mode to SIMV to spontaneous breathing trial, which is CPAP and extubation. But more and more and more, we in clinical practice go from AC to CPAP and extubation. Sometimes we don't even put the patient on CPAP on a ventilator on the ICU. We look at the amount of volume that they're pulling and their ratio out, tube out. But you can answer that way, right? Do you understand? SIMV and AC mode. Yes?
Yes.
Good. Pressure support. Here I am delivering pressure. Okay? So never mention volume, never answer volume in your exams. Okay? So basically, it's no more than a preset pressure that I set up in a ventilator as a backup if the patient doesn't breathe properly. That's it, okay? So basically, it's the mode of spontaneous respiration as well. For example, guys, it's easy, it's not difficult. Never, ever, ever answer pressure support on an AC mode, right? Because AC mode is rate, tidal volume, FiO2, and peak. Why would you need a support if you're fully mandated? Doesn't make sense, right? But even though synchronized, intermittent, mandatory ventilation, every time the patient doesn't breathe at the preset rate or below, the machine will deliver volume, right?
Yeah.
But you cannot control the pressure. So if you need an extra support on a patient that has a lot of atelectasis, etc., you also will add, this is an add-on, a pressure support, right? So the SIMV modes are, the formula, all right, is no more than, again, rate, but can you control the rate if the patient is breathing on their own? No, I'm just putting a rate of 12 just in case the patient breathes below. But if the patient breathes above, I can control that, right? Tidal volume. That one I can control, right? Because it's synchronized, intermittent, mandatory ventilation. I am controlling the volume, right? I can also put the FiO2. I can also put a peak, but remember, this is my physiological peak. And if I need an extra support in case the patient doesn't breathe on their own, or the patient breathes below 12, I can apply pressure support. And the pressure support is between 6 to 8, 6 to 10, depending on how much support the patient needs, right? So, again, patient have an inspiratory effort, but it's weak, and you need an extra support, you put pressure support, right? So, as I told you, you basically control the rate, but the patient can breathe over that, tidal volume, and the duration of inspiration. So, let's imagine that I want to start SIMV on you, right? And if your calculation was rate of 12 and 480, and a FiO2 of, you need to be at 50% already, and a PEEP of 5, I will put SIMV of 12, tidal volume of 480, FiO2 of 50%, PEEP of 5, and pressure support of, really depends on you, if I see you more awake, right? I would put what? This minimum. And the minimum will be equal to your PEEP. 5? If you need a little bit extra support because you're kind of like, you know, you're an SIMV, but you just went through a stroke and you still don't open your eyes, even though your chest X-ray is normal, you don't have secretions, but you're like, let me put 8, let me put 10. Really depends on how the patient is doing. Okay? The same with the CPAP. Okay? What is CPAP? Continuous positive alveolar pressure. The difference with CPAP is that the patient is breathing on completely. And actually, by definition, sometimes equal or a little bit more higher than atmospheric air. Because you can have a patient on CPAP at 25%. I've had it. And you still cannot take them out of the ventilator because they don't have a good tidal volume on their own, but they're at 21%, 25. That's the minimum that I can put in the ventilator. Do you understand? That the patient is continuously breathing spontaneously. Okay? So, you can manipulate the PEEP, but if the patient is breathing on their own, can you manipulate rate?
No.
Can you manipulate volume?
No.
What can you only manipulate? Put the FiO2 and the PEEP, but really again, on the patient's clinical status, you will put an extra support.
So you don't manipulate the volume either, right?
No, you can't.
Just an FiO2 and the pressure. It's like a little CPAP.
Correct, correct. So, again, what would be the parameters of CPAP if the patient is completely breathing on their own? I would only put the rate on the machine for what reason? In case the patient breathes less than that, right? So if I put rate of 12, can I put that volume? I can. Yes or no?
Yeah.
I can't.
No?
The patient's breathing spontaneously, completely.
But what about if they go below?
That's the reason why you have pressure support. Okay? So, FiO2, if you have a patient on CPAP, you should never be more than 50%. Okay? So 50% or less, you can put a PEEP, let's imagine 5, and you add pressure support. Okay? 6 to 8 or 10, depending on the patient's clinical status, how strong or weak the patient is. So tell me, what is assist control?
That's when the patient
Breathe for you.
It doesn't matter what the breathe is gonna.
It's always gonna.
Correct. So regardless of the patient's effort, the machine is going to deliver a preset volume. Right? SIMB?
SIV, that's the one.
It is synchronized with the patient's own breathing. And I would only deliver the preset volume if the patient doesn't breathe spontaneously. But the patient is allowed to breathe on their own tidal volume as well.
Yeah, but if it's older, then they breathe.
CPAP. The patient is breathing spontaneously at a pressure, remember it's no volume, at a pressure just a little greater than atmospheric air. Alright? And you can add pressure support in SIMV and CPAP.
But not
SIMV, CPAP, pressure support are modes of weaning the patient from the ventilator. Do you think assist control and pressure control are weaning modes? No. So the rest are. The rest are. Okay? So what is PEEP? It's no more than the positive and expiratory pressure that I am applying to that alveoli at the end of expiration. That I will start physiologically at 5, but as I need more alveoli expansion or less preload, I will increase. Right? So we went through the initial settings, right? I don't have to. We went through the calculation of ideal body weight. We went through examples, yes or no? Okay.
Oh, we didn't go the obesity. We don't need it
Next semester.
Next semester is on.
Basically what happens is that you have to increase 30% more.
More multiplication.
For B's, it's a different formula. You see, ideal body weight, you have to go by 0.4 actual body weight minus ideal body weight. So it's basically a 30% more.
Okay, disregard next semester. Disregard. Sure. Let me just go next semester. And next semester.
As I told you, again, I know it's too much for you. Listen to me. Listen to me. How much FiO2 should I have? Right? Because, again, I told you, go slowly, and that's the way to do it. But in reality, there's formula for everything in pulmonary. So how much should I have my FiO2 based on the PaO2? How much should I increase? How much should I decrease? It's based on this formula. You want to calculate more? I'm not going to make you calculate more, but I have to make you aware that if you desire a 90 to 100%, right, of PaO2, you need to calculate your actual FiO2. For example, if I'm at 50% FiO2, I need to multiply by my desired PaO2, which is 90 minimum at least, right? Yes or no? Divided by my actual PaO2. So, for example, if you have 50%, so 50, right? Multiply by 90 minus, imagine that the actual PaO2 is, I don't know, 82. Divide, I'm sorry. You divide 90 by 82, and then you multiply by 50, and that is exactly the desired FiO2 that you should have. So what FiO2 should I put on the parameters of the ventilator to be able to get me my 90% desired?
It says 54.87.
Okay?
So 50.
Will this work the same
Exactly,
way if you
50%.
have a patient that's overcompensated, like if you, like that example that you've given us that the oxygen, that the VO2 was like 300 something, and you wanted to wean them off, like would that work as well?
Of course.
Like you would, like
Of
one
course, if you have, for example, the actual FiO2 that I have is 100%,
Right.
100% multiplied by 90, let's say, for example, divided by 300, how much is that?
30.
I'm not gonna make you do that.
So
So that means that if I have 100%, you should go down to 30. But I'm not gonna go down to 30, so let's do 50. Do you understand? So that patient safely, you can go from 100 to 30%, but that's kind of like,
That's really low, so you go 50.
right? So that's the reason why you can see that practitioners go from 100 to 50 because of that.
Because it would be a value
So,
much lower than that. So safe value like in between.
Exactly. Are you guys lost?
No.
All right, so you can also adjust the rate based on formula. You can also adjust the tidal volume, even more after the ideal body weight. You can also adjust the beat based on formula and a table that is present in ARDS.net. But that's a lot.
So
We
important
need to know the basics first.
important question, for boards, we need to.
Know this.
Not that?
No. What they want you to know, number one, calculate the tidal volume based on ideal body weight.
Okay.
Number two, they need to know that you know what initial settings you're gonna apply on the ventilator and what mode you're gonna select, which is AC. And third, you need to know the definitions of all the modes.
Right.
Which is everything we just.
So, you go up on this, you go up on that. They need to know that you know that that manipulating rate and tidal volume, you change the CO2 levels, and also the PEEP and the FiO2, the oxygenation level. That for them is more than enough. All right? So, another part, plateau pressure, okay? Remember that I told you that plateau pressure is no more than, you basically stand in front of the machine. There is different tabs, right? You have a tab for rate, volume, and FiO2. You have inspiration, expiration. You can hyperoxygenate the patient with 100% before suctioning and so forth. There is a tab that you press and you basically hold inspiration. When you hold inspiration, remember that what happens is that you produce increased pressure in the alveoli, right? That is called plateau pressure, okay? So if you see, listen to this, remember that you need to have a plateau pressure less than 30, right? So, just listen. Hey, listen. So it could make sense, all right? If you have an increase in inspiratory pressure and plateau pressure, so that means that you come, you hold, and the patient has, instead of less than 30, you have 40, 50, that's an increased plateau pressure, right? If you have an increased plateau pressure, okay, and the patients, if you look at the machines, have you seen ventilators ever in your life? No, I mean, many students have never gone through.
It's in paper.
He's outpatient, he has never seen a ventilator, okay? So if this is a ventilator here, this is the monitor of the ventilator. Listen to me, this is the ventilator, okay? And right here in the corner, you're gonna see your positive inspiratory pressure. This positive inspiratory pressure, again, should never be more than 30, the same as plateau pressure. If you have both pressures increased, okay, basically what you have is problems with the lung parenchyma. But if you see the ventilator going in, high pressure, because this pressure is increased, and you want to know if it's really the lung, what's doing that is increasing the resistance, right? The compliance, right? That the lung is rigid. Remember, compliance is the expansion. And if it's increased, you cannot expand properly, right? You have like fibrosis. Yes or no?
Yeah.
So, means that if you have problems with compliance, the pressure in the lung will increase and the ventilator will be ping, 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 alarming, right? Let's do a holding inspiration to see if my positive inspiratory pressure is highly coinciding with my plateau pressure. If both are increased, I have a problems with compliance. That means my lung parenchyma is affected. What's doing this is the disease process. Okay? But if I now have an alarming ventilator due to my inspiratory pressures increased, and I hold that inspiration and my plateau pressure is less than 30, which is normal, what happens is that I have a dead space. Look for fluids in the tubing. The patient biting the ET tube. There's a mucus plug. The filter is dirty. The tubing is kinked.
Or the pressure is disconnected.
That is low pressure.
That's low pressure.
So high pressure alarming, that's what you could get. The maximum that you could get on examination, on board examination is, if you have a high alarming pressure, which is a nursing 101, if you have an alarming high pressure on the ventilator, what could it be? They don't even mention the patient. Kinking in the tubing, patient hiding the tube, fluid in the tubing, secretions plugging the filter, and so forth. If you have a low pressure, balloon is deflated, the patient is disconnected, the patient extubated himself, but you're nurse practitioners. Can I see? I see that I have high pressure and the patient is like comatose. And you look at the tubing and nothing is going on, let me check. Hold plateau pressure, hold inspiration and measure. The machine will tell you, you don't have to calculate anything. The number plus. If that number is more than 30, you're not treating the patient properly or the prognosis is really poor. That means that from a pulmonary edema, your patient's prognosis is going to run back. Again, from a normal pneumonia, if you get a high peak pressures with a high plateau pressure, that patient is closely to ARDS. Do you understand? It's a very rigid lung.
So in that case, you would increase the P.
Yes. You have to increase PEEP at expense of more alarming, but it's necessary. Do you understand?
Can I just summarize for a second? So, okay, so the increase, that one and the one on the left, that just means that everything's increased. When you hold the button, the plateau is still gonna be increased, so it's just being pro prognosis for the patient, because the lung compliance.
Or, for example, maybe you're missing a pneumothorax.
Or you're missing something, it's just bad.
You're missing something. Maybe the fusions are larger and now you have to do thoracentesis. Maybe the patient has a pneumothorax and that's the reason the pressure increased. Let's do a chest X-ray again and see, because maybe the patient's PEEP of 12 and it wasn't alarming before, giving you high pressure. Now the patient's alveolar collapse and you have a pneumothorax. Do a chest X-ray, something else is going on. Do a chest X-ray and see if the patient has a pneumothorax and put a chest tube. But if you go through diagnostic test of exclusion and you do a chest X-ray, there's no more pulmonary edema, there's not a pneumothorax. Look at always the belly, because when you see the patient getting worse and worse and worse, and the lungs are clear, it has happened to me a lot. That means that we're missing an abdominal condition. Okay? I had a patient that it was UTI, sepsis, UTI, respiratory failure, intubated. The X-ray clear, and the patient's demand for oxygenation was higher and higher and higher. The abdomen distended, and nobody was looking at it. CT abdomen was done, and guess what? The patient had an abscess in the gallbladder. Whenever you see that the clinical status of the patient doesn't match with the diagnostic evaluations, in case I'm talking about lung, clear chest X-ray, and a high FiO2, and the patient's still not getting oxygenated, you have a PE, or you have something in the abdomen. Look for something else. That we miss the abdomen a lot, okay?
Which
Pressure
one?
increases. You're not ventilating the both elevated. You have high peak and high plateau. You're only ventilating one lung and not the other. And it's gonna give you high pressure because the patient is not oxygenating properly, okay?
The machine, this.
So again, simple as do another chest x-ray, look for the belly. If there's nothing clear cut, that means that the patient is getting worse. Okay? You have to start talking to the runner. So this is a long history of smoking, captain observation, where a non-invasive ventilatory support, this is BiPAP, okay, has lasted 4 hours. The patient's breathing has progressively worsened, is uncooperative. These are the key words that I don't want you to miss. Uncooperative and agitated. Can I put BiPAP on a patient? No. The patient must be alert, awake, oriented, cooperative. So first of all, intubate. ABG, severely acidotic. Hypercapnic, so this is respiratory acidosis. This is the FiO2, and the PaO2, 68. So hypoxemic, hypercapnic, respiratory failure, mixed respiratory failure. Do you understand? What will you do? Number one, intubate the patient.
Increase the receptor.
Parameters on the ventilator.
Rate
Off. Ooh, you have to think now.
The rate has to be high.
The rate has to be higher than 12.
Yes.
I don't care what number you plug in, but you would not choose 12. Do you understand? Unless I tell you in the question that the patient was already at 12, what will you do next? Do you understand, yes or no? Guys, if you start this patient from the beginning at 12, this is not gonna get better, it's gonna get worse. Do you understand? I need to know that you know that this parameter has to be moved. Right? So never start at 12 on this patient. Start 40, 16, but never at 12. So your answer will never be 12. Okay? 100% and a PEEP of 5. Now, what do we really do in clinical practice? Hey, what do we really do in clinical practice? I know that if this is a COPD patient and I start at 100%, this is gonna triple. So I start, if that patient was already on BiPAP, listen to this, how do we do it in practice? If this patient, if I tell you that this patient was already on BiPAP, and the BiPAP settings were IPAP of 16, EPAP of 5, FiO2 of 50%, and backup ratio of 14, listen what we do. On 50%, she was at 68 on a COPD patient, that's fine. Let me decrease this FiO2 to be able to manipulate the CO2. So I, clinically, and I see a lot of changes. We went through, a program that, if you know the disease process, you know how to start. Now, how do residents or ER start? Same, 12, this, 100, but then the adjustment will be higher. So what I would do is, I will start the ventilator on an AC off higher than my iPod, because it wasn't working, right? AC off, let's see, 18 or 20, okay? My FiO2 lower than that, so 50, 68, 40%, right? Tidal volume was already calculated, and my PEEP of 5. Do you understand? Yeah. And you would see that an APG an hour after will be even better. But unfortunately, you can't do that on the test, right? If I ask you, What will you do with this patient? Intubation. What ventilator mode will you choose? Assist control. What are the parameters? AC of at least 14. I didn't give you parameters before. At least higher than 12, right? At least 14. An FiO2 of calculation that we already, I'm sorry, tidal volume of calculation that we already went through. At 100% and people 5. Do you understand?
Yeah.
Good.
But it wouldn't be 100%, would it?
In real life, it's not.
In real life, but on a test, you have to always start at 100%. If you answer based on clinical practice, you will lose it. You will lose it. Okay? So, another COPD, unfortunately, you have a respiratory rate of 25. On 24%, that's almost nothing. 21 is atmospheric. This is 1 liter. 1 liter. 24% ventimask. She has a heart rate of 125, blood pressure normal, but SpO2 is 88%. Already using intercostal retraction, intubate the patient, right? What's the major problem here? You have a 50-50, right? That's your plot. You will see that the majority of these patients are like, but on an exam, meets the criteria for respiratory failure, right? PCO2 of more than 50, PaO2 of less than 60, so this patient has a hypercaribic, hypoxemic respiratory failure. As you see, the bicarb is already high, so the patient's compensating, it says chronic, right? So I have a mixed respiratory failure, you intubate the patient. Tell me the settings. AC off.
At least.
I'm only at 51. 12. And then you can adjust, right? So 12, calculated tidal volume. FiO2 at 100% of people 5. Easy, got it?
Yeah.
18, you're drowning. 26, heart rate of 127. SpO2 is 81. Diffuse fine crackles. That's water.
So you're gonna.
I need to decrease my preload, right? With my PE. Overload, movement, is confused.
So
Yeah,
it's-
Combative. Can I put it right back? No. 733. 51. Hypercapnic, hypoxemic,
Dying.
respiratory failure. So, settings on the ventilator. AC of 12, calculated tidal volume, 100% on people, more than 5. That's what we expect. Status post exposure to toxic chemical, respiratory rate of 45. Retracting, deeply cyanotic. On a non-rebreather at 82. Crackles. Intubate. Right?
Yes.
Now, the patient is breathing this is another technique.
Alkaline.
The patient is breathing 45. Okay? Now, try not to blunt as much the respiratory rate on the patient. The CO2 is still within normal limits, right? But what do you think will happen if wait. On a 45 rate, he should have less of that CO2. I would be like in the 20s. Yes or no? That means that, listen, this is a little bit more advanced, but that means that if you give me a 12 as straight here, when I'm breathing at 45, what's going to happen? So I'm not saying that you would increase, you put the rate on the setting of the ventilator at 45, but I will go at least half of that, right? I will go at least at AC of 20. And let's see what happens in the next APG. Because I can guarantee that if you put AC of 12 on a patient that is breathing 45, the next CO2 on the ABG is going to be 80. You're blunting the physiological response of that patient. The same as guys, if you ever see, this is another example. Imagine that I have a 726, right? And I have 24 in CO2. And I have on my, forget about the PO2, let's put it whatever, 80, okay? And I have my bicarbo 15 and base excess of -7. Have you learned in pathophysiology that metabolic acidosis are compensated with Kussmaul respiration? What happens if you give me an AC of 12 on a metabolic acidotic patient that is compensating with hyperventilation? It's gonna go worse. You're blunting autoregulation. So those are things you're gonna learn in clinical practice later, okay?
How much time do you wait to do another ABG? After you change something on the machine, how much time do you wait until the next ABG?
In reality, 30 minutes is enough.
30 minutes.
30 minutes is enough.
So it would be on an AC of 20, no?
Yes. Because you have to think about all those things.
Base excess. I always have that question every time I see this.
Well, normally, the basic is the amount of alkaline that is present in your body, right? So the bicarbonate is a form of alkaline, but their other electrolytes are non-measured, like phosphate is one, albumin is another one. So those remaining electrolytes or solutes that are not measured are called base excess. And they're also called anion. Okay, so 18 years old, brought to the ER, unresponsive. Are you gonna put it back? And those are questions that are coming in the selections. This, and that. Okay? Alcohol consuming, paramedic reported vomiting in the oral cavity, difficult intubation, copious foreign matter, patient was on bagging 100%, saturation remains at 80%, the chest x-ray shows orange. I forgot the x-ray, I guess. So if I put you bilateral diffuse pulmonary edema with a PaO2 or FiO2 ratio less than 300, what would you think? This is ARDS. And now my question to you is, how much tidal volume should I give to this patient? 4 to 6 mLs per kilo.
Right.
At which extent should I increase the parameters of the ventilator? PP. Those are the questions that you get in ARDS. Okay? This is an example. You have a patient with diabetes ketoacidosis, 725, PaCO2 34, PaO2 is 82, bicarb of 60, the blood sugar is 475. Her breathing is difficult, attributed to Kussmaul respiration. Judging her DKA non-critical, the admitted physician placed her on a general medical ward, began appropriate treatment with insulin and fluids. 4 hours later, she appears dyspneic. These are the ABG. From 725, she went to 718. PCO2 already at 49, she's getting tired of breathing fast, right? That's the reason why she's retaining CO2. Look at the PaO2 from 82 to 52, and bicarb of 18. You have to intubate this patient. That's the, remember when I started saying that respiratory failure not only is hypoxemic, hypercapnic, and preoperative as well as hyperperfusion, but acid-base imbalance. This is a criteria for intubation as well. Now, how would you start that patient on a ventilator? Patient is breathing. This is the patient that you can never start at 12 as well. You have to mimic what the patient is doing. Look at the rate that the patient was putting at and try, I'm not saying 32, but at least try to mimic that. So if it's 32, put it in half, 15, 16, right? Never at 12, because otherwise the patient's retaining CO2 because of you, all right? So when should I, this is another question that you get, when should I win the ventilator off? When is the patient ready, all right? trigger the patient to be on the ventilator should be eliminated, right? The underlying condition is well treated. If you have, again, at least, if you had a PaFiO2 ratio of less than 300, at least I need you to be over the ratio that you started with. If it was 200, more than that. If it was 150, more than that. So start or have a PaO2 ratio greater than your initial parameters, okay? If you have a PEEP, remember that you start with 5 of PEEP, right? But imagine that the patient had a severe pulmonary edema or ARDS. You were already at 15 of PEEP, 20 of PEEP, but you're already at 7.5 and 50% FiO2 or less, you're ready by numbers. So this is 0.5 is 50% of FiO2. So if you are less than 7.5 PEEP, less than 50% FiO2, your underlying condition is well treated, your initial FiO2, PaO2 ratio is greater than what you started with. Your pH, if your major problem was hypercapnic and your pH was 7.15, or your metabolic acidosis that your initial pH was 710, for example, I need you to at least be more than 7.25, okay? And no hemodynamic instability, since it was one of the indications for intubation, and the capacity of the patient to take deep breath. So sometimes we do pulmonary mechanics, old school. You need to do also a leak test. So basically you deflate the balloon, and if you have a tube in your trachea, this is your trachea, and this is your ET tube. And it has a balloon right here, not to allow the ET tube to come out. Think rational, okay? And if I take this balloon, not only the machine will start beeping, but what about air flowing out? So you would hear air coming out through the tube, and that is good. So that's a positive early test. In addition, look at the tidal volume on spontaneous breathing. If the patient calculated or expected tidal volume was 500, and the patient's pulling 500 or more, that's good, okay? The patient's able to raise the head of the bed. Tell the patient, put your head away from the pillow. So that means that not only the head is okay, but you don't care about the head, right? But if you have strong muscle strength in the head, you're going to have it in your intercostal and diaphragm, right? The patient is not on vasopressor support. Even though now we have seen extubations on clinical, on the hospitals, on 5, 7, 8, should be less than 7.5, right? And on 5 of vasopressor or 10 vasopressors, shouldn't be. If you're still on vasopressor, what does that mean? You're not hemodynamically stable. And we do it in clinical practice, but in your exam, you're not ready to be extubated if you're still on vasopressor support, okay? Other modes of weaning, besides the one that I gave you. If your patient failed spontaneous breathing trial and you cannot take the tube out and you have to do tracheostomy on the patient, on the tracheostomy, you can still have your ACMO, your ACIMV, your spontaneous breathing trial, your pressure support, right? But what else can you do? Oxygen, right? Regular oxygen. You could do tray collar, let me tell you the difference. It's just that an empty mask placed on the hole. Okay? Or T-piece. The T-piece, the advantage is that the same sterile suction that you have when the patients are intubated are placed on the TPs. So it's no more than you have the drink and you have like a little piece like this and the suction technique. So if you see that the patient is able to be off completely the ventilator, but their problem is secretions, you can put this whatever amount of oxygen, 21, 24, 25, 28, 30, 40, 50, but with the suction technique, okay? That's called TPs. I showed you this already. Who's failing to wean? It's not because the nurse is busy or the respiratory therapist cannot follow the patient. The appropriate clinical status that can say that the patient is failing to wean is you put the patient on spontaneous breathing trial or SIMV, and when you do an ABG, same night, an hour after, the following day, the ABG is worse. Put the patient back on whatever parameter the patient was before. If the patient becomes tachypnic, but remember, tachypnea by itself is not a failure to wean, because have you ever breathed through that tooth? I did. I had a motor vehicle accident once, and I had flail chest tubes, and I was intubated. And I can tell you that you are breathing under the ocean through a straw. Can you imagine yourself being under the ocean and try to breathe through a straw? That's how you feel. So sometimes tachypnea and tachycardia can mean anxiety, right? Look at the patient's volume, look at the oxygenation, talk to your patient, give anxiolytics, and see if that is the reason. Bring the family inside to help you coach, because otherwise the patient will never leave the ventilator, right? Many patients show their own personality. If you're really strong and anxious, you won't be able to breathe. You have to have the capability of relaxing yourself and think about it. And I can tell you that it's difficult, okay? So, cardiac arrhythmias is a no-no. Put the patients back on the ventilator. If you see that the blood pressure spikes high, really high, get anxiety. Look for anxiety first before you say, oh, no, respiratory, put the patient back. I know it's your convenience, but, so, hemodynamic instability, and that means alterations in blood pressure, heart rate. The patient's ABG are worse and deteriorating. If the patient's diaphoretic, that one for sure. That one for sure.
So
Okay?
the patient,
Don't do like trauma patients. I mean, in Kendall Regional, they put the patients in trauma, breathing on their own for 1 and 2 days. Oh my God.
so what if the patient gets, why is he intubated, gets like confused with the outcome?
Intubated?
Yeah, can we do
There'll be a sedation.
The patient's sedated or non-sedated?
No, sorry.
And the patient becomes confused?
I can see.
Well, you do an ABG because the patients can be confused due to CO2 retention. Or it could be a stroke.
Exactly.
Either or. Oh no, of course. First of all, do an ABG and see why the patient is confused. If it's due to the retention of CO2, then you put the patient back on the ventilator. If the ABGs are okay, look for another source of confusion. That has to be a stroke or something. Okay? Or metabolic. Alright? And as I told you, you can do an ABG 30 minutes. Any question? Yes. And I haven't even covered asthma and COPD. Okay, let's see what we do for asthma.
Wait a minute, there's another thing.
Quickly. Do you remember that stepwise approach?
Yes, we also gotta do the.
Okay. What would be the first line treatment for a patient that has asthma? Short-acting beta-agonist, right? So, albuterol. Let me open it so you can see what I will ask you. But it's easy, it's not difficult.
No, just a step while I do that.
This is the guideline for asthma. Remember, asthma is the hypersensitivity reaction type 1, that you release your eosinophils and histamine, right? It's a basically hyperactive airway disease, it's a obstructive pulmonary disease. This is all pathophysiology. Okay? So, first of all, how do you diagnose asthma? The only way to diagnose asthma is by pulmonary function test, right? And what is the value that you're going to look for in pulmonary function test? The forced expiratory volume in 1 second, that is severely decreased, right? Okay? So, what are you expecting as well when you diagnose the patient with asthma? When you do a pulmonary function test, and you give a patient a bronchodilator. How else can you diagnose asthma? If you have at least 21% increase in that forced expiratory volume in 1 second after bronchodilator therapy, the patient has asthma. So number one, how do you diagnose asthma? By pulmonary function test. The most reliable value to diagnose a patient with asthma is the forced expiratory volume in 1 second that is severely decreased. And if you give a patient an albuterol, you're expecting 30 minutes after an improvement of at least 21%. Okay? Now sometimes you believe, for example, my son, you have to have asthma because I have asthma, my family has asthma. You run and you get wheezing and bronchospasm, but I'm not sure you don't get it anywhere else, and sometimes you run and nothing happens. Let's do a broncho provocation. So basically you give the patient an allergen and see if the patient reacts, if the airway reacts and the patient becomes bronchospastic. You should imagine that this test is only done in a clinical control setting hospital, right? Because the patients can go into status asthmaticus and respiratory failure. Okay? Do you diagnose with chest x-ray? No. With any biomarker? No. Okay? Remember that gastroesophageal reflux disease mimics asthma. Many patients are diagnosed of an adult onset asthma and they don't have asthma. And what they have is that they're inhaling toxic fumes from the acid of the stomach, and that produces wheezing. Most commonly in the early morning, the patients have a history of GERD, they have a chronic cough, so rule that out too.
Usually no.
Yes. I have everything highlighted in yellow, where you should know. But, tell me,
No, they missed the last one.
tell me.
No, there's some paper that I had, I did outlines, tengo que sent it to her. No te
Oh,
preocupes, está bien, está muy bien hoy.
Muy bien.
Sí, todo muy bien.
Now, what else should you do? Remember that NSAIDs and aspirin can trigger asthma. Remember this is back pathophysiology, okay? You have the eicosanoid cascade, the leukotrienes, right? That basically aspirin can trigger bronchospasm. So whenever the patient is in acute status asthmaticus, never give, at that time, I'm not saying in the entire life, when the patients are going through acute bronchospasm, I'll try to avoid aspirin and NSAIDs. I know that if the patient has a stent or the patient has an MI, and at the same time has a status asthmaticus, you have to give the aspirin. There's no other choice, right? No. You have to give aspirin and relate down on MI, right? So you have to give it. You cannot avoid that one. Remember also the beta blockers that are non-cardiogenic, right? That you have, if the patient has propranolol, for example, can trigger asthma, so always try to choose metoprolol or atenolol. And of course, eliminate all the allergens that the patients might have contact if you can actually determine which. Treatment. The classifications are, you have the short-acting beta agonist, which is your albuterol and levobuterol, right, Sovanex. You have the long-acting beta agonist, which is your salmeterol, one of them. I'll give you a prototype, okay? And you also have your inhaled corticosteroids. I can tell you, for example, budesonide pulmicort is one of your prototypes. In addition to that, you have the injectable corticosteroids, your IV steroids. You have your methylprednisolone or solomedrol is there. You have your leukotriene modifiers, which you have there your Singular, okay? And Montelukast is there, okay? In addition to that, you have also adjuvants of treatment, which, for example, you have your theophylline, theophylline is there. And anticholinergics, which your Atrovent is there in the list. We now have Duonep, which is combined albuterol with ipratropium bromide. But remember that what they love to ask in asthma, since asthma, there's no sputum production. There's no high amount of mucus secretion. Anticholinergics are never in the stepwise approach. They are the first line, along with albuterol in COPD, but not in asthma. Okay? That's one of the questions for the board. Remember that even though it's common sense, they love to ask whenever you do nebulizers with inhaled corticosteroids with Pulmicort, rinse your mouth because you can get fungi. This is the same thing as aspirin and NSAID. Here it is. Now you're not going to touch children, you're going to go straight to adult. Right here. First of all, you have the classifications of asthma. Classifications of asthma, I just want you to remember this. Listen to me. Listen, I'll help you with it. Okay. You have asthma, mild, moderate, and severe. Okay? The mild, you have two types. Intermittent and persistent. How do you know the difference of intermittent and persistent? Basically, how many times you use your nebulizer. Okay? Listen to this. If my patient now tells me that they use their nebulizer less than 2 days per week with a normal PFT, and here in the mild persistent, they have more than 2 days a week. Let me give you an example. Mild intermittent, would be, for example, less than 2. So that means that I use it only maybe Monday. But in the persistent, Monday and Wednesday. Okay? Even though my PFT remains normal. In the moderate, I use it daily, but one time. Monday through Sunday, but maybe only in the morning when I wake up. But as you could see here, in the severe, you use it several times per day. And in addition to that, the difference between mild to moderate and severe is that in moderate, besides of, I'm using my nebulizer daily but one time, my PFT is already at a 60% FEV1. Again, mild, normal FEV1 more than 80%. In the mild intermittent, one daily, one time per week. In the mild persistent, 2 times per week, but normal PFT. Moderate, daily, but one time daily. And I already have an FEV1 of 60%, right? 60 to 80. Severe, I use it several times per day, and I have less than 60%. I already at severe, you should be in the hospital. It's a red. You have the colors as well. Green is mild, moderate is yellow, and severe is red. Okay? That is the classification. And the treatment, really easy as well. Come for the first time to treat asthma. What would you do first? Albuterol. Come back. Patient doesn't get better. Sometimes you don't see them anymore because they go to the hospital. But if they come back to you, what would you do next? You would add a low inhaled corticosteroid. So you would add, for example, Pulmicor 0.25.
Lava, then lava, so then it would be sour plus lava.
No, that's not lava.
That's not lava, that's corticosteroid.
That's inhaled corticosteroid.
Oh, like, the discus.
Pulmicor, no.
That's fine, right?
The discus has the Pulmicor plus lava.
Ah.
Doesn't have Saba. Okay? Salmeterol. Okay? So, first, albuterol. Doesn't work. You add the low Pulmicor. It doesn't work. What will you do next? Medium Pulmicor plus albuterol. Remember, I will never ask you alternative treatment. It will never be your next choice. Then you would do medium inhaled corticosteroid, which is Pulmicor, plus albuterol, plus salmeterol. In the third stage is when you add lava. Then I will go to my highest level ICS, which is a Pulmicor, plus albuterol, plus salmeterol. Do you understand? And at the last stage, you already in the hospital, is when you give me, it says oral, but it's really not oral, IV corticosteroid. The alternative of treatment are whenever you wish to add them in the second stage. So the next step in your question will never be the answer singular or theophylline or anything like that. It will always be here. Okay? That is asthma.
So after step 2 is when you would be able to add like the singular or whatever you want in addition to.
You're in the hospital, of course you're not going to do PFTs in the hospital unless the patient gets better. But if you get to answer that question in the classification, you have a patient with, remember the hospital, you're here. Already, right? In this stage, never here. If you're here and I give you the treatment, and I would do, which I would never do, a PFT right after, and you get a 21% increase or improvement, and you will never be classified as asthma, you have asthma. You're here outpatient, which of course is less, right? You're distressed. You're here and I give you SABA and I haven't been able to diagnose you before of asthma, and I see a 12% increase on your pulmonary function test, you have asthma. I'm expecting more, less. But again, that's the way to diagnose asthma, but the best way to diagnose asthma is by doing pulmonary function test. Any question on asthma? That's the only thing I can make. That's the only thing. And COPD is very, very similar. Remember, the difference with COPD and asthma is that COPD has chronic bronchitis, which you have an abundant sputum production for the past 3 months, consecutive 3 years. So it's like, so you need to reduce that amount of phlegms, and the best way to reduce the phlegms is by giving anticholinergics, not only for that reason to prevent infection, right? Those secretions are harbor of microorganisms, right? There's a pool of phlegms that can be co-infected. So not only you're preventing pneumonia, but you're preventing rehospitalization, okay? And remember that the other component is emphysema. COPD also has a classification, and the COPD classification is mild. Your FEV1 remains normal, but remember, normal in quotation, because you should, even though I've seen 50 years of age with COPD, you're expected to be an elderly patient. So that's the reason why the new accepted, which is not going to be on your exam because it's brand new, we start at 70% in COPD because we also take into account the age of the patient. Moderate, you're between 80 to 50% of your forced expiratory volume in the first second. Severe is 50 to 30% that at this stage the patient should be also in the hospital. And very severe, less than 30%, and that patient should be intubated, okay? And the treatment is very similar to asthma. This is basically what do you give, the bronchodilator therapy and the mechanism of action, which is pharmacology. But I'll go through the actual stepwise approach for them. Give me 1 second.
I think it's on page 19.
Got
It's on page 19.
19?
There.
You just passed
Hold
that.
on. After that page.
Oh, there you go. But I can't.
Yes,
Maybe open another tab.
Oh my goodness.
Very little. So here's a classification based on FEV1, okay? But what should you do on the patient, treatment-wise? First, what do you give on an asthma patient in the first step? SABA, right? So albuterol. But what should you add on a patient with COPD? Atrovent, right? Yes, antibiotic. Yes. Atrovent. So in the first step, as soon as you see a patient with an acute COPD exacerbation, and when do I know that the patient is exacerbated? First of all, the chronic bronchitis, the classification is the abundant spiritual production, right? But what about if I just basically feel a little bit in a cough, but now is full? That's a change in quantity.
Yeah.
And if it was yellowish beige and now it's green, that's a change in color, right? So a change in quality and color of the sputum is an acute exacerbation. Yes. In addition to that, if the patient becomes hypercapnic or hypoxemic, right, that's an acute exacerbation. So, number one, albuterol plus atrovent, which is your duoneb, plus antibiotic. Even though we use levaquin in the hospital for all COPD patients, the guideline says amoxicillin, and you have to answer as such. Okay? So, the same as asthma, guys. What will you do next? ICS. Inhale corticosteroid. Give me the Pulmicort. And you go up and up and up on the Pulmicort onto the third stage that you add the LABA, right? And that's when you can give me the Discus Advair, which has the LABA plus the SABA, right? And inhaled corticosteroid. The LABA plus the inhaled corticosteroid. Or if you wish, you could give me a Discus of ipratropium bromide, which is Piriva. So, but I'm not going to ask you like that. SABA plus atrovent plus amoxicillin, then ICS, right? Pulmicort. Go up on the Pulmicort, add the LABA, salmeterol. And then at the end stage, what will you add? The same. IV solumetrol. What else do you need to add on the patient with COPD? Vaccinations, influenza, and pneumococcal vaccine. And if the patients are in severe or very severe, when the patients are discharged, which rarely I see, but we do, pulmonary rehabilitation. And of course, smoking cessation therapy, and blah, blah, blah. If the patients don't smoke and you don't see the risk factors, do an alpha-1 antitrypsin level.
So just to know confused, in asthma COPD with the Pulmicort, you pretty much maximize the dose before going to LABA. You don't.
No,
That's why I'm confused.
you go low, medium, LABA, high.
Okay, that's why I had it ready. That's
Yes,
what
same thing.
The same
Same thing. Okay? What you have to do across the board is your vaccination and at the end stage, pulmonary rehabilitation.